Good morning, everyone. Today we are going to discuss leftover topics of thyroid. Today we'll see iodine-associated thyroid disease. Iodine is essential micronutrient and is key component of T4 and T3, as we all know. WHO recommends 150 microgram per day of daily intake in adult men and women. Higher levels are recommended for pregnant women. Dietary sources of iodine include seafood, dairy products, eggs, and grains. Dietary iodine deficiency is a major worldwide public health issue. It is associated with development of thyroid nodules and goitre. Suspected iodine deficiency can be assessed by measuring iodine in urine, either 24-hour collection or spot sample. Endemic goitre can be treated by iodine supplementation, and reduction in nodule and goitre size can be seen, particularly if it is commenced in childhood. In pregnancy, iodine deficiency is associated with impaired brain development, and severe deficiency can cause cretinism in baby. Iodine deficiency is most common cause of preventable impaired cognitive development in children. WHO and other international organizations made reversal of iodine deficiency by implementation of national programs like iodization of table salt, or administering IM or oral iodized oil to at-risk population, or addition of iodine to wells. Iodine-induced thyroid dysfunction. Very high concentrations of iodine inhibit thyroid hormone synthesis, that is known as Wolff-Chaikoff effect. This forms the rationale for iodine treatment in thyroid crisis. That's why in thyroid crisis or in thyrotoxicosis before thyroid surgery, we give iodine. That is a very high concentration of iodine inhibits the thyroid hormone synthesis and release, that is Wolff-Chaikoff effect. This is autoregulatory response because this is a protective mechanism, as it inhibits the large amount of thyroid hormone release in response to ingestion of load of iodine. That is, if any person consumes more of iodine, it inhibits the release of excess of thyroid hormone. This Wolff-Chaikoff effect has a beneficial effect. This effect lasts only for about 10 days, after which it is followed by escape phenomena, essentially the return to normal organification of iodine and thyroid peroxidase action. Therefore, if iodine is given to prepare an individual with Graves' disease for surgery, operation must happen within 10 to 14 days. Otherwise, relapse of thyrotoxicosis could occur. In iodine deficient parts of world, transient thyrotoxicosis may be precipitated by prophylactic iodine iodinization programs. In iodine sufficient areas, thyrotoxicosis can be precipitated by iodine containing radiographic contrast medium or expectorants in patients having underlying thyroid disease predisposing to thyrotoxicosis. Induction of thyrotoxicosis by iodine is called as Jod-Basedow effect. Chronic excess iodine administration can result in hypothyroidism. Just now we have seen that is Wolff-Chaikoff effect. Coming to Amiodarone. This is antiarrhythmic agent which is analogous to T4, and it has huge amounts of iodine. 200 mg contains 75 mg of iodine. Amiodarone also has a cytotoxic effect on thyroid follicular cells, and it inhibits the conversion of T4 to T3. Most patients receiving amiodarone have normal thyroid function, but up to 20% develop hypothyroidism or thyrotoxicosis. That is, intake of amiodarone can cause hypothyroidism or thyrotoxicosis. So thyroid function should be monitored. TSH provides the best indicator for thyroid function. So amiodarone-induced thyrotoxicosis can be classified as either type 1 or type 2. Type 1 is iodine-induced excess thyroid hormone synthesis. That is jod-based effect. Type 2 is thyroiditis due to cytotoxic effect on follicular cells. These patterns can overlap and may be difficult to distinguish clinically, as iodine uptake is low in both. So there is no widely accepted management algorithm, although the iodine excess renders the gland resistant to iodine 131 therapy. That is, there is no use of giving iodine 131. Antithyroid drugs may be effective in patients with type 1 form, that is jod-based effect, but are ineffective in type 2 thyrotoxicosis. That is, there is damage to the follicular epithelial cells, there is no action of antithyroid drugs. Prednisolone is beneficial in type 2 form. A practical approach is to commence combination therapy with antithyroid drug and glucocorticoids in patients with significant thyrotoxicosis. That is, if the patient has amiodarone-induced thyrotoxicosis, we do not know. If we do not know it is type 1 or type 2, the practical approach is to start with both. A rapid response usually indicates type 2 picture and permits withdrawal of antithyroid therapy. Slower response suggests type 1 picture in which antithyroid drugs may be continued and prednisolone is withdrawn. Potassium perchlorate can also be used to inhibit iodine trapping in thyroid. If the cardiac state allows, amiodarone should be discontinued, but it has a long half-life, that is 50 to 60 days, so its effects are long. To minimize the risk of type 1 thyrotoxicosis, thyroid function should be measured before giving amiodarone therapy. Amiodarone should be avoided if TSH is suppressed. Hypothyroidism should be treated with levothyroxine. That is, we have seen that amiodarone can cause thyrotoxicosis as well as hypothyroidism. In hypothyroidism, levothyroxine should be given. Coming to simple and multinodular goitre. Simple diffuse goitre. This form of goitre usually presents between age 15 and 25 years, often during pregnancy. It is usually noticed by friends or relatives. The patient may have tight sensation in the neck, particularly when swallowing. Goitre is soft, symmetrical. The thyroid enlarged to 2 to 3 times normal. There is no tenderness or no lymphadenopathy or overlying buoy. Concentration of T3, T4 and TSH are normal. No thyroid autoantibodies are detected in serum. No treatment is necessary as goitre usually regresses. In some, however, stimulus may persist and there may be episodes of hyperplasia or involution following 10 to 20 years. Gland may become multinodular where there may be autonomous function. Coming to multinodular goitre, that is coming to natural history of simple goitre. In the age group of 15 to 25 years, there may be a simple goitre that can become a multinodular goitre over the age of 55 years, and the tracheal compression or deviation is present in multinodular goitre, and T3 and T4 are normal in the age group of 25 and 26 to 55. More than 55, T3 and T4 are raised and the TSH is undetectable. Patients with thyroid enlargement in the absence of thyroid dysfunction or positive autoantibodies as young adults may progress to develop nodules. These nodules grow at varying rates and secrete thyroid hormone autonomously. Ultimately, complete suppression of TSH occurs in about 20% of cases with T4 and T3 level often within the reference range. That is, subclinical thyrotoxicosis, or sometimes T3 and T4 are elevated, that is toxic multinodular goitre. Clinical features and investigations. Multinodular goitre is usually diagnosed in patients presenting with thyrotoxicosis, a large goitre with or without tracheal compression, or sudden painful swelling causing hemorrhage into nodule or cyst. Goitre is nodular or lobulated on palpation and may extend retrosternally. However, not all multinodular goitres causing thyrotoxicosis are easily palpable. Very large goitres can cause mediastinal compression with stridor, dysphagia, and obstruction of superior vena cava. Hoarseness due to recurrent laryngeal nerve palsy can occur, but is far more suggestive of thyroid carcinoma. Here in this picture we can see this is a CT showing multinodular goitre with the retrosternal extension. It is causing the compression of trachea. It is causing tracheal compression. The diagnosis can be confirmed by ultrasonography or thyroid scintigraphy. In patients with large goitres, flow volume loop is good screening test for significant tracheal compression. If intervention is contemplated, CT or MRI of thoracic inlet should be performed to quantify the degree of tracheal displacement, compression, or retrosternal extension. Nodule should be evaluated for the possibility of thyroid neoplasia. Coming to management, if the goitre is small, no treatment is necessary, but annual thyroid function should be arranged. The natural history is, as we have seen, it can progress to toxic multinodular goitre. Thyroid surgery is indicated for large goitres which cause mediastinal compression or which are cosmetically unattractive. Iodine-131 can result in significant reduction in thyroid size and may be of value in elderly patients. Levothyroxine therapy is of no benefit in shrinking multinodular goitres in iodine sufficient countries and may simply aggravate any associated thyrotoxicosis. In toxic multinodular goitre, treatment is usually iodine-131. Iodine uptake is lower than in Graves' disease, so higher dose. In Graves' disease, the uptake of iodine is increased. So lower doses of radioiodine may be required in treatment of Graves' disease, but coming to multinodular goitre, the uptake is lower than in Graves' disease, so higher doses may be administered up to 800 becquerel and or 20 millicurie. In thyrotoxic patients with large goitre, thyroid surgery may be indicated. Long-term treatment with antithyroid drugs is not usually employed as relapse is invariable after drug withdrawal. Drug therapy is normally reserved for frail older patients in whom surgery or iodine-131 is not an appropriate option. Coming to thyroid neoplasia, we have seen iodine-induced thyroid disorders and simple and multinodular goitre. Now we are going to discuss thyroid neoplasia. Patients with the thyroid tumors usually present with a solitary nodule. Most are benign and few of these called toxic adenoma secrete excess thyroid hormones. Primary thyroid malignancy is rare, accounting for less than 1% of all carcinomas. It can be classified according to cell type of origin. That is, thyroid tumor originating from follicular cells can be differentiated or anaplastic. In differentiated carcinoma, there may be papillary or follicular. And the tumors arising from parafollicular C cells are medullary carcinoma, and tumors arising from lymphocytes, that is lymphoma. We will see in detail. Toxic adenoma. A solitary toxic nodule is a cause of less than 5% of all thyrotoxicosis. Nodule is a follicular adenoma that autonomously secretes excess thyroid hormones and inhibits endogenous TSH secretion with subsequent atrophy of rest of the thyroid gland. The adenoma is usually greater than 3 centimeters in diameter. Most patients are female over the age of 40 years. Although many nodules are palpable, the diagnosis can be made only by thyroid scintigraphy. So the thyrotoxicosis is usually mild in almost 50% of the cases. Plasma T3, that is T3 thyrotoxicosis may be seen. Iodine-130, 400 to 800 megabecquerel or 10 to 20 millicurie is highly effective and is an ideal treatment since the atrophic cells surrounding the nodule do not take up iodine and so receive little or no radiation. That is, as there is autonomous nodular hypersecretion of thyroid hormone and the rest of the cells are suppressed, so only the autonomous nodules take up iodine 131. There is little risk to the normal follicular epithelial cells. For this reason, permanent hypothyroidism is unusual. Hemithyroidectomy is an alternative management option. Coming to differentiated carcinoma, in that we have seen two types, that is papillary carcinoma and follicular carcinoma. Papillary carcinoma is most common of the malignant thyroid tumor and accounts for 90% of the radiation-induced thyroid cancer. It may be multifocal and spread is initially to regional lymph nodes. Some patient presents with cervical lymphadenopathy and no apparent thyroid enlargement. In such instances, primary lesion may be less than 10 mm in diameter. Coming to follicular carcinoma, this is usually single encapsulated lesion. Spread to cervical lymph nodes is rare. Metastases are blood-borne and are most often found in bone, lungs, and brain. Coming to management, large tumors, those with adverse histological features or tumors with metastatic disease at presentation are usually managed by a total thyroidectomy, followed by large dose of iodine 131, that is 1100 or 3700 megabecquerel or 3200 millicurie, to ablate any remaining normal or malignant thyroid tissue. Thereafter, long-term treatment with levothyroxine in dose sufficient to suppress TSH, usually 150 to 200 microgram daily is given. As there is evidence that growth of differentiated thyroid carcinoma is TSH dependent, that is why we give levothyroxine replacement. Smaller tumors with no adverse histological features may require only thyroid lobectomy. Follow-up involves measurement of serum thyroglobulin, which should be undetectable in patients whose normal thyroid has been ablated and who are taking a suppressive dose of levothyroxine. Thyroglobulin antibodies may interfere with assay when we measure thyroglobulin, that is after iodine 131 treatment. The thyroglobulin should be undetected, but measuring thyroglobulin can be interfered by thyroglobulin antibodies. So detectable thyroglobulin in the absence of assay interference suggests tumor recurrence or metastasis, particularly if the thyroglobulin titer is rising across serial measurements. Local recurrence or metastatic disease may be localized by ultrasound, CT or MRI or whole body scanning with iodine 131 and may be treated with further surgery and or iodine 131 therapy. Iodine 131 treatment in thyroid cancer and isotope scanning both require serum TSH concentrations to be elevated. For the iodine 131 to be uptaken by the follicular epithelial cells, TSH concentration should be more than 20. This may be achieved by stopping levothyroxine for 4 to 6 weeks, inducing symptomatic hypothyroidism, or by administering intramuscular injections of recombinant human TSH. The second option, that is IM human TSH, is costly. It is not routinely practiced. Those with locally advanced or metastatic papillary and follicular carcinoma, that is refractory to iodine 131, may be considered for therapy with sorafenib or lenvatinib. These drugs are multi-targeted tyrosine kinase inhibitors. They have multiple toxicities like weight loss, fatigue, diarrhea, or mucositis, hypertension, blood dyscrasias, rashes. The potential benefits of therapy therefore have to be carefully weighed against side effects that can significantly impair quality of life. Coming to prognosis, most patients with papillary and follicular thyroid cancer will be cured with appropriate treatment. Adverse prognostic factors include older age at presentation, presence of distant metastasis, male sex, and certain histological subtypes. However, iodine 131 therapy can be effective in treating those with distant metastasis, particularly small volume disease in lungs. So prolonged survival is quite common in follicular and papillary carcinoma. Anaplastic carcinoma and lymphoma. These two conditions are difficult to distinguish clinically but distinct cytologically and histologically. Patients are usually over the 60 years of age and present with rapid thyroid enlargement over 2 to 3 years. Goitre is hard and there may be stridor due to tracheal compression and hoarseness due to recurrent laryngeal nerve palsy. There is no effective treatment for anaplastic carcinoma, although surgery and radiotherapy may be considered in some circumstances. In older patients, median survival is only 7 months. A prognosis for lymphoma, which may arise from pre-existing Hashimoto's thyroiditis, is better, with median survival of 9 years. Some 98% of tumors are non-Hodgkin's lymphoma, usually the diffuse large B-cell type. Treatment is with combination chemotherapy and external beam radiotherapy. Medullary carcinoma, these arises from parafollicular C cells. These produces calcitonin, and in addition to calcitonin they produce 5-hydroxytryptamine, serotonin and peptides of tachykinin family or ACTH and prostaglandins. As a consequence, it may lead to carcinoid syndrome and Cushing's syndrome. Patients usually present in middle age with firm thyroid mass. Cervical lymph node involvement is common, but distant metastases are rare initially. Serum calcitonin levels are raised and are useful in monitoring a response to treatment. Despite the very high levels of calcitonin, hypocalcemia is extremely seen. Hypercalcitoninemia can be associated with severe watery diarrhea. That is, hypocalcemia is rare, but it may present with watery diarrhea. Treatment is by total thyroidectomy with removal of regional cervical lymph nodes. Since the C cells do not concentrate iodine and they are not responsive to TSH, so there is no role of iodine 131. External beam radiotherapy may be considered in some patients at high risk of local recurrence. Vandetanib and cabozantinib are tyrosine kinase inhibitors, which are used in patients with progressive advanced medullary cancer. Prognosis is less good than for papillary and follicular carcinoma, but individuals can live for many decades with persistent disease that behaves in indolent fashion. Medullary carcinoma of thyroid occurs sporadically in 70 to 90% of the cases. In 10 to 30% of the cases, there may be genetic predisposition. The gene involved is red gene. The inherited tendency normally forms part of MEN syndrome, that is MEN2, MEN2A, MEN3, that is MEN2B. Susceptibility to medullary carcinoma is the only inherited trait, that is familial medullary thyroid cancer. Coming to Riedel's thyroiditis, this is not a form of thyroid cancer, but presentation is similar to that of thyroid cancer. That is, differentiation can usually be made only by thyroid biopsy. It is exceptionally rare condition, unknown etiology, and extensive infiltration of thyroid and surrounding structures with fibrous tissue is present. There may be associated mediastinal and retroperitoneal fibrosis. Presentation is with a slow growing goitre that is irregular and stony hard. There is usually tracheal and esophageal compression requiring partial thyroidectomy. Other recognized complications include recurrent laryngeal nerve palsy, hypoparathyroidism, and eventually hypothyroidism. Okay, this comes to the end of the topic thyroid. So in thyroid we have seen the anatomy and physiology, functional anatomy and physiology of thyroid gland, and presenting problems in thyroid gland, that is hyperthyroidism or thyrotoxicosis, hypothyroidism, thyroid growth, that is thyroid nodules or thyroid growth, and asymptomatic thyroid thyroid test abnormalities. And we have discussed autoimmune thyroid problems like Hashimoto's thyroiditis, Graves' disease, and we have discussed about iodine-induced thyroid diseases and how amiodarone can cause thyrotoxicosis and hypothyroidism. And we have also discussed about the goitre, simple goitre or solitary simple goitre or multinodular goitre, and in thyroid growth, that is thyroid neoplasm, we have seen solitary thyroid nodule. We have discussed about uh, differentiated carcinoma, anaplastic. Differentiated, we have seen follicular and papillary carcinoma, anaplastic carcinoma, and we have seen lymphomas of thyroid and its management, and we have seen tumors of parafollicular C cells, that is medullary thyroid cancer. So, and the rest leftover topic in thyroid is congenital thyroid diseases. It can be thyroid hormone resistant or dysharmonogenesis. In dysharmonogenesis, we have seen functional anatomy, and while discussing functional anatomy and physiology, we have discussed the formation of thyroid hormones. That is, thyroid must be uptaken into the cell. Iodine must be uptaken into the thyroid follicular cells through the basolateral membrane, and into the apical membrane there is a pendrin transporter. That defect causes pendred syndrome. So the dysharmonogenesis is one of the congenital thyroid abnormalities. The other thyroid abnormality is thyroid hormone resistance. That is where the thyroid hormone acts. There is a defect in the receptor of the thyroid in the pituitary or hypothalamus. So there is increased TSH production, but the receptors of thyroid present elsewhere can be normal. So it can present with thyrotoxic features and increased TSH levels, as the receptors in the pituitary and hypothalamus are normal and are defective, and the receptors elsewhere are normal. So they can this presentation of thyroid hormone resistance can be with thyrotoxic features and increased TSH. So this comes to the end of thyroid topic. So in the next class we will discuss about the disorders of reproductive system. Thank you.